Good evening, everyone. My name is Bojia, and today I will be walking you through the newest evidence on a single practical question. That being, if we treat obstructive sleep apnea with continuous positive airway pressure therapy, does the fatty liver disease that so often accompanies it get any better? So, by the end of this half hour, you will know what the best science, published as recently as last year, says on this topic, and why the answer is still evolving, and what it means for tonight's patient. So, first of all, let's begin with three definitions that will be repeated throughout the talk. First being obstructive sleep apnea, or OSA. So imagine a collapsible straw in your throat, right? Because during sleep, the straw kind of kinks, and air stops, and oxygen dips. So the brain startles you awake during the night just enough to reopen the airway, and this cycle can repeat dozens of times throughout the hour. 1 in 8 adults worldwide live with at least moderate OSA. So, secondly, non-alcoholic fatty liver disease, NAFLD, it is exactly what it sounds like. It's fat not caused by the liver, accumulating inside liver cells. Left unchecked, this condition can inflame and scar the liver, in a stage we call NASH with fibrosis. 1 in 4 adults globally has NAFLD. And then third, continuous positive airway pressure, CPAP, which is a bedside blower that delivers a steady airflow through a mask, acting kind of like a internal air splint that keeps the collapsible straw that we talked about before open. So CPAP is basically the golden standard therapy for moderate to severe OSA. So the problem here is why these conditions matter together, right? Because Riazi's 2022 meta-analysis puts global NAFLD prevalence at 38%, basically one in every 3 adults. And among our sleep apnea patients, the overlap is even higher. Mersawi's 2019 review quotes 58% to 78%. And in raw clinic numbers, that is basically 2 out of every 3 faces you see in a CPAP teaching room, for example. So why exactly should we bring sleep and the liver to the same table today? Because the overlap we see between these two conditions is pretty staggering. When we screen OSA patients, roughly 2/3 already carry extra fat in their liver. Conversely, when hepatologists biopsy NAFLD patients have turned out to have significant OSA. And we believe this is not just a harmless coincidence because these two diseases can often amplify one another in a 4-step vicious cycle. First of all, OSA produces intermittent hypoxia and fragmented sleep. And secondly, hypoxia can trigger oxidative stress and systemic inflammation. And third, inflammation accelerates insulin resistance and lipid mishandling, pouring even more fat into the liver. So the resulting metabolic dysfunction worsens both cardiovascular risk through mechanisms we do not fully understand the severity of OSA itself. So just to put plainly, basically what we're talking about is that the patient with both diseases can face a higher risk of a heart attack, faster progression to liver fibrosis, and earlier onset of type 2 diabetes. Okay, so Siri, however, in this stage offers hope because if hypoxia drives the liver injury, then eliminating hypoxia with CPAP should necessarily break the process, right? Because animal data from Moretto 2012 and Arnold 2021 show that cycles of low oxygen, even at a mild frequency, can turn on hepatic stellate cells, the very cells that lay down the collagen scars on your liver, independent of body weight. So if that insult is oxygen dips, and if CPAP can abolish these dips, then we should logically remove the insult. The mechanistic chain is what today's trials are trying to I'm sorry about the little mistake there. So hypothesis, of course, should probably meet the cold light of controlled evidence. We'll be concentrating on 5 papers today that taken together represent over 1,000 patients and follow-ups from 6 months to 3 years. 2 are randomized sham-controlled trials in 2021 and Giampa 2022, the current gold standard, and 3 are longitudinal cohorts, being Shapur 2010 and Kim 2018 and Hirano 2021, which can give us a real-world adherence pattern of how these two diseases interact with one another. So in the hierarchy of medical knowledge, basically RCTs, randomized controlled trials, sit at the top because randomization can balance out both the known and the unknown confounders. And this can basically let us isolate the true biological effect of CPAP. And cohorts come second because they reflect real life, which is a great thing, but they can also be distorted by the healthy user effect, which we will also talk about later on in the discussion section, because patients who stick with CPAP every day and every night often also adopt other healthier behavioral habits. So, what exactly do these studies measure? Ng and Giampa used MOI-PDFF, which is an imaging technique that counts the fat molecules in the liver with a precision of 0.5%. And Shapur used CT liver attenuation. Kim and Hirano used the cheaper bedside tools that you may also probably know, ALT and AST and APRI fibrosis score. So basically, what the abbreviations here means that, first of all, being ALT and AST, right? Because these are the enzymes that exist inside liver cells. And when the cell membrane is injured, they leak out into the bloodstream. So a higher blood level of these enzymes means that there are more ongoing liver irritation. And ALT, the enzyme, is fairly liver specific, but AST, on the other hand, is also found in the heart and the muscle. So we usually look at the pair of the enzymes together. And then we have APRI score, which stands for AST to Patalat ratio index. It's basically a one-line calculation of AST divided by upper limit of normal divided by Patalat count. Because Patalats fall and AST rises as fibrosis worsens, the index kind of gives a rough needle-free estimate of scarring on the liver. So values above 1.5 makes us worry about significant fibrosis, and above 2.0 worried about cirrhosis. And then we have the third concept, which is CT attenuation. A standard CT scanner basically measures how much X-ray is being absorbed, and fat usually absorbs less X-ray than water. So by comparing the number in the liver with the number in the spleen, we get the liver attenuation index, which is the lower the liver number, the fattier the organ. One advantage of this method is that one scan can cover the entire liver, but the disadvantage is that the method also causes radiation and has incredibly high costs. So in short, ALT and AST can tell us about the current irritation, APRI hints at scar tissues, and CT attenuation tells us how much fat is actually sitting within the liver cells. And then we have the follow-up windows here. Basically, we have 6 months in the RCTs, and one year in Kim's study, and 2 to 3 years in Shapur. Okay, so moving on to the positive evidence in the first 3 studies, Kim's 2018 retrospective cohort featuring 351 US veterans showed a 25% fall in ALT and a parallel drop in APRI, but only in those who kept the mask on more than 4 hours per night. And Shapur followed 72 Israeli patients for a median of 30 months, which is 2 to 3 years. CT liver fat, expressed as the liver to spleen attenuation ratio, improved by 6% in compliant users, but also worsened slightly in non-users. And now Hirano's 2021 Japanese cohort added a nuanced mean complex compliance index and still found enzyme improvement even in a no weight loss subgroup, which suggests that it has an anti-inflammatory signal. Now moving on to the randomized control trials. Ng's group randomized 90 Hong Kong adults to therapeutic CPAP or whisper quiet sham devices. At 6 months, MRI-PDFF was 15.2% in both arms, identical to the decimal. Liver stiffness on FibroScan also refused to budge or change. Giampa's 2022 Tritosa MS trial across 5 Brazilian centers achieved metabolic syndrome reversal in 18% of CPAP users versus only 4% in the placebo strip group, which is a statistically significant win. Yet, when the statistics may have unpacked the syndrome, individual components, including fasting glucose, triglycerides, and HDL, were unchanged. And the MRI sub-analysis then again showed no reduction in liver fat overall. So we see that both trials can have performed a covariance adjustment for weight change. So once that the single variable entered the model, the CPAP regression coefficient basically collapsed to 0. So in plain language, the scale, not the machine, moved the liver. Okay, so why do observational studies cheer while randomized controlled trials remain pretty silent? A few reasons. First of all, studies of design hierarchy, because association is not necessarily causation. And secondly, observational research is often vulnerable to the healthy user halo because people who persevere with a nightly mask therapy are also more likely to swallow a salad, climb a flight of stairs, or turn up for appointments over a long period of time, which means that they have healthier life habits. But then randomization, on the other hand, by giving motivated and unmotivated patients an equal chance of receiving a real or a sham device, basically strips away that halo and leaves us with the pure biology of air pressure versus placebo. And now, third, we have outcome measures. We see that different studies also use different methods of outcome measurement, such as blood tests versus imaging, which can also lead to different results. So finally, all of the above kind of brings us to the elephant in the room, body weight, because across both RCTs, every kilogram drop in the body weight predicted a 0.4% absolute fall in MRI-PDFF. So to achieve the clinically relevant threshold of 30% relevant reduction in liver fat, a 7% to 10% weight loss remains necessary, which is exactly the figure that Chalasani's 2018 ASLD guidelines continue to endorse. So CPAP may indirectly help by restoring energy, reducing daytime sleepiness, and giving the patient the stamina to, for example, diet and walk. But the machine itself cannot necessarily melt liver fat. And randomized trials, by equalizing placebo effects and behavioral support, unmask this inconvenient truth. Because observational studies lacking that control, on the other hand, credited CPAP for the benefits that perhaps rightly belong to the lifestyle change on itself. So at last, let us therefore be precise about what CPAP does and does not do for the liver. What it does is that it reliably abolishes apneas, it improves sleep architecture, it lowers nocturnal blood pressure, and may also dampen systemic inflammation. But what CPAP does not do is that it does not reduce hepatic fat on MRI or CT. It does not reverse fibrosis as measured by a FibroScan. It does not improve individual glucose or lipid parameters or serve as a standalone NAFLD treatment. So in short, CPAP is excellent OSA medicine, but it's not necessarily liver medicine. So how should we exactly counsel the patient that carries both diseases? Let's just basically walk through the steps, right? Step 1, we should probably initiate CPAP for the sleep disorder full stop because symptom relief and cardiovascular protection are reason enough for this assignment by itself. Now, step 2 is that we should probably prescribe a structured weight loss program. For example, 500 calories daily deficit, 150 minutes of moderate exercise per week, and behavioral coaching. 7% weight loss remains the first line, evidence-based NAFLD intervention. And now step 3 is that we monitor. We should monitor and check liver enzymes at 6 months consider repeating imaging if advanced fibrosis was present at the baseline. And step 4, in those with confirmed NASH and fibrosis, add pharmacotherapy such as vitamin E or emerging GLP-1 receptor agonists under hepatology guidance to treat both diseases. But we probably shouldn't expect one treatment to cure both diseases magically. But then our ignorance in this domain is pretty much far from vanquished, as we can see, because we still not know whether CPAP plus intensive lifestyle intervention is, synergistic or merely additive. And we have not identified the phenotype. Perhaps the patient with profound nocturnal desaturation who might also enjoy a liver-specific dividend. And all sham-controlled trials stopped at 6 months. So maybe the benefits of CPAP require years to manifest. And we also lack granular mechanistic data, because does anti-inflammatory ripple of CPAP translate into lower fibrosis progression decades and decades later? Answering these questions will probably demand multi-center trials, costly MRI endpoints, and genuine interdisciplinary cooperation between sleep centers, liver clinics, and nutrition scientists in the end. So basically, let me just close this presentation today with 4 take-home messages primarily. First being, CPAP alone, rigorously tested, does not meaningfully reduce hepatic fat or fibrosis. And secondly, CPAP is nonetheless crucial for OSA control, and OSA control prevents cardiovascular events. And third, weight loss, whether achieved through diet, exercise, medication, remains the only intervention proven to reverse NAFLD. And fourth, optimal care is integrated care. Sleep specialists, hepatologists, dietitians, and primary physicians rowing in the same direction can aid OSA patients and NAFLD patients to recover in the future. So that concludes my speech, and thank you for your attention today. I will now be happy to answer questions from the audience.